Welcome to the Plant-Free MD podcast with Dr. AnthonyChaffee, where we discuss diet and nutrition and how this affects health and chronic disease, and show you how you can use this to optimize your health and happiness, both mentally and physically. Hey guys, just want to take a second to thank our sponsor, the Carnivore Bar. I don't promote many products because honestly, all you need to be healthy is to just eat meat. But for those times that you're out hiking, road tripping, or stuck at work and you want a nutritious snack that is just meat, fat, and salt if you want it, the Carnivore Bar is a great option. So I like this product not because it's just pure meat, but also because I want the carnivore market to thrive as well. And the more we support meat-only products, the more meat-only products there will be available in the mainstream. So if this sounds like something you'd like to get behind, check it out using my discount code Anthony to get 10% off, which also applies to subscriptions, giving you 25% off total. All right, thanks guys. Hello everyone, this is Dr. Chaffee, and I have a very special guest today, Dr. Aseem Malhotra, who I met first when we did the Actim cholesterol debate a few months ago with Dr. Ross Walker. Aseem is a British cardiologist, public health campaigner, author of several books, such as A Statin-Free Life and the Poipi diet. I'm probably not pronouncing that right. Pioppi. That's much more Italian, and 21-day immunity plan. He's been involved in many organizations activating for better nutrition and better health across the UK and the world, such as Action on Sugar and now the Public Health Collaboration, or PHC, was named the Sunday Times one of the 500 most influential people in the world. And Aseem, thank you so much for joining us. I really appreciate you coming on. How are you?
I'm great. Thank you for having me, Anthony.
Yeah. So obviously, apart from the bio, if people don't know sort of what you work, what are you working on now? What's a bit of your background? Tell us, who you are.
Yeah, sure. So I qualified in 2001, Edinburgh Medical School in Scotland. I grew up in Manchester. Both my parents were GPs. So I came from a kind of medical family, if you like. And quite early on, I decided I wanted to pursue a career in cardiology, even as young as the age of 11. And part of it was motivated by the death of my older brother, who died of what was probably viral myocarditis, actually, when he was 13. So that obviously was a very traumatic experience for the whole family. And then once I went to medical school, my interest in cardiology only increased. And I was like, well, this is what I want to do. And then I subspecialized in interventional cardiology, which you'll know is to do with putting in heart stents and treating heart attacks, and which I was, I really loved, and I was good at it. But then my career took a little bit of a different path from the conventional route. Not longer after I became a consultant, in fact, I started before then, but essentially I became also a campaigner and activist, using various platforms, including medical journals, mainstream media, social media, to try and initiate change that ultimately will improve public health. And I got to that position having had clarity that a lot of what was driving people's health decisions and was based upon misinformation rooted in commercial interests, essentially, whether it's to do with the food industry or whether it's to do with the pharmaceutical industry. And from my perspective, I've sort of been the two key areas that I've heavily campaigned on are improving the food environment and nutrition education. And in that journey, one of the roles I had was being science direction of Action Sugar, and really, I suppose, being the first person in this country to get mainstream media awareness, certainly as a doctor, on the harms of excess sugar. And then that translated into advising politicians and policy changes. And we then got a sugary drinks tax introduced here in the UK a few years ago. So that was one of the big roles, or one of the big achievements, I would say, that I've been involved in. And then simultaneously, for the last sort of 10 years, inspired by the BMJ's Too Much Medicine campaign, I've been very proactive in highlighting the problems with medical research in terms of quality of data, commercial interests, and then downstream, ultimately, lack of informed consent that takes place when in terms of discussions with doctors and patients about many drugs. Of course, we've discussed statins, and we could talk about that as well, I'm sure. But for me, what my main motivating factor in all of this work, Anthony, is one, how can I be the best possible doctor I can be for my patient? but for the primary purpose of improving their outcomes, which specifically means, in general terms or in broad terms, relieving their suffering, managing risks, and treating illness. So everything I do in terms of my work is motivated by that.
Yeah. Well, that's great. Yeah, I'm right there with you with the special interests. Manipulating and influencing people for decades and pushing us in the wrong direction. And then people say there's like they feed us the wrong thing and then they give us some medicine to treat the bad outcomes. And whether or not that's coordinated, it certainly does seem to be the case that we're going down the wrong path, we're eating the wrong things, we're getting sick, we're getting unhealthy, and then we have an entire medical establishment that profits on that unwell that sort of poor behavior and poor health. And unfortunately, everyone thinks that this is the right thing to do, that they're eating healthy and that this is just a normal way of aging, and that these medicines are actually providing benefit when they don't necessarily in all cases, especially when you're sort of treating something that doesn't need to exist in the first place. Can you tell me a bit about what you're doing with PHC and what you guys are trying to get going in the UK?
Yeah, I'm glad you asked me that question. So I'm my role now is I'm the president of the collaboration. and public health collaboration really is made up of a group of doctors, other allied healthcare professionals, including dietitians, nutritionists, pharmacists, nurses, members of the public, and patients. And that's why it's a collaboration. It's slightly different. What separates us from other charities is that collaboration, and also being removed from commercial interests. A lot of charities, unfortunately, with the best intentions, are funded by industries that see them as a useful branding opportunity for their products, for example.
Yeah.
So we are funded by the public for the public interest. And what we're trying to do is inform people to make healthy decisions, but also simultaneously understand that a lot of the drivers behind disease processes in the population and in individuals, Anthony, are structural drivers. Mm-hmm. So we talk about the social determinants of health. Another way of a better way of kind of for help, a better way to help people understand what that means is to talk about the biopsychosocial model. So really, the conditions in which we are born, in which we grow, in which we live, in which we work and age, those conditions themselves have a role to play in driving our behaviors, but also very much rooted in often psychosocial stress. So for example, if you are in a high demand, low pay, low control job, that's in effect, I would say that is a death sentence. So we know there's very good data showing that, that probably through psychosocial stress mechanisms will increase cardiovascular disease risk over time. So I think it's important for us to understand that most of our choices when it comes to health behaviors are driven by situations that are beyond our immediate control. And therefore, although it's really important to educate individual patients, and that's what we do, we have to simultaneously appreciate that unless we sort out the environment in which those unhealthy behaviors are being fueled, we're not going to have a real big impact that we want in terms of population health. And this is a population health crisis when you think about obesity. And therefore, it needs a population intervention. Doing stuff at the grassroots is very important. Let's not underestimate that. As individuals, we can help so many people individually, of course. But how do we translate what you and I know, for example, when it comes to eating real food or avoiding ultra-processed food? How do we make sure that's translated, that becomes the default for everybody?
Yeah.
So really, public health collaboration is focusing at the moment primarily on issues around the diet situation. And moving forward, of course, we want to promote more ethical medical practice through informed consent and shared decision-making with pills, which, as you know, is very much tied to those lifestyle interventions. So, for example, if we are helping patients send their type 2 diabetes into remission, simultaneously they're going to come off some of their pills, which is great. But that conversation involves helping patients understand that actually the pills themselves may only have a very marginal effect on their health, mostly don't improve quality of life, and can come with side effects. So once that conversation starts, it does help, I think, motivate those patients more to actually be in a situation where they're very happy, often, more often than not, and I'm sure you know this, Anthony, to come off the pills. People, by and large, if they can avoid it, once they're given the full information, don't really want to be taking pills if they can avoid it. And therefore, of course, the lifestyle is another alternative for them, and often an additional tool for them if they want to carry on with the pills, of course, to improve their quality of life.
Yeah. And how did you decide to make that transition from working as an interventional cardiologist to then, think that you're going to make more of an impact in this way? What sort of drove you to take that turn?
Yeah, I think it was incremental, Anthony. From a personal level, a lot of what I do is informed by my own patient contact. So over a period of, say, 10 years, from 2001, when I qualified as a junior doctor, to getting over to sort of 2010, on a visceral level, on a clinical experience level, I was seeing more and more patients that were coming in with lifestyle-related diseases, more polypharmacy, so patients on multiple medications. And I could see that their outcomes weren't improving in the way that they should be. And that obviously was associated with them, being more affecting them mentally too, in a negative way. And then, of course, you match that with what's going on in terms of population data and understanding. In the UK, for example, we've had this problem with overweight, people being overweight or obese, which is 60% of the adult population, for almost 2 decades now. And we haven't really made much inroads into tackling that. Yeah. So it was matching those two things, and then actually looking then and saying, well, hold on, what's the root cause of this problem? For me also, because I'm a cardiologist, I was specifically interested in cardiovascular disease. And it was fascinating for me to learn that the biggest impact on reduction in death rates from heart attacks in the last 3 or 4 decades has been curbing tobacco control. It hasn't come from some magic pill. I'm not saying that pills and emergency care don't have a really important role. Of course they do. But when you look at the biggest impact, at least 50% of that impact on reduction in death rates from heart disease happened from tobacco control. So specifically taxing cigarettes, public health education campaigns, but also smoke-free buildings, public smoking bans, that kind of thing. And then it was interesting when I looked at, obviously I'm also by nature, like a lot of people are, a foodie. I grew up in a household where we valued home-cooked food. I learned to cook when I was 16 by my dad. I cooked through most of my university career, most days of the week. And so I still cook. I love cooking. And I appreciate the importance of nutritious, healthy, home-cooked food. And then once I looked into the data, data that was appearing on the impact of how diet can have probably similar, if not stronger effects on a larger scale as quitting tobacco in terms of improving or reducing one's risk of heart disease very quickly, I then felt that I needed to be an advocate for that movement to promote dietary changes that are going to reduce cardiovascular morbidity and mortality. And I published a paper in BMJ Open Heart specifically on that. I think it was 2014, if I'm not wrong. So, that was one of the things that motivated me as well, is actually the fact that dietary changes can very rapidly, within a few weeks, massively improve cardiovascular risk factors in selected patients that are at high risk. And that's a really powerful message. And it wasn't infiltrating itself into clinical practice. Most doctors, as you know, don't get any training in nutrition. Mm-hmm. I had to learn all of this on my own, if you like, and obviously looking at other research that's done by other people. And then really what I do is put the jigsaw together and try and translate it into something that's going to have meaningful impact for the population, for patients, in a way that's understandable for most people. So I think that's probably my role as a clinician and as an academic clinician.
Yeah. Oh, very good. And, I think that is absolutely one of the most important things. Obviously, like you say, we can do things as a grassroots movement and talk to people one-on-one. And that's certainly, something that I've done for a number of years, but you really do have to start, branching out and getting a bigger impact. And like you say, you need to address the root cause. I think that's the most important thing in medicine, is to identify what is actually causing this and to try and target that. Whereas right now we're just sort of papering over things and it's sort of disease management and symptomatology, and we're just sort of putting band-aids on things while everything's just falling apart around us, and we're just ignoring the fact that the rates of these illnesses and diseases have increased dramatically in recent years, and not many people are asking, well, why the hell is that? Like, obviously something's happening. We're changing something in our environment. Our genetics aren't going to change that quickly, and so something is happening in our environment. What is it? And I think obviously, smoking is huge, and I think that diet is such a major player as well. So it's great to see people like yourself really fighting that fight and trying to take this to higher levels as well, to make this much more aware by the medical population as well, and then disseminate that out to the population at large. In your estimation, you've been working in this field for a decade or more. What needs to be done at this point, at the stage that we're at now, to get this as a mainstream idea that nutrition actually makes a very, very big impact on our health, and get this out to clinicians and to people at large, and maybe get policy changes to reflect these sorts of things as well. What sort of needs to be done at this stage?
Yeah, it's a great question, Anthony. So before I answer that, I think one of the things that would help your listeners understand a little bit more of my role on all of this as a cardiologist is actually looking back. The obesity epidemic seemed to take off in the 1980s, and there's a very clear correlation. Of course, correlation doesn't necessarily imply causation between changing dietary guidelines globally, where we went for this low-fat food movement, if you like. And that was driven by heart disease concerns, which had increased massively from the 1920s, peaking in the 1960s. Of course, scientists trying to figure out what was the cause of it. And that was before they fully appreciated the impact of smoking. And of course, diet was part of that flawed understanding, if you like. And then everything got focused on lowering cholesterol. And as a result of this focus on lowering cholesterol, the food industry then obviously adopted to those guidelines and produced a lot of low-fat, ultra-processed, cheap, refined carbohydrate foods, which now certainly, in my opinion, and I'm sure many other people agree with this, are certainly a big driver, if not the main driver, behind metabolic dysfunction and obesity. So once I kind of figured that out, I then wrote a very provocative article on the BMJ in 2013 called "Saturated Fat is Not a Major Issue." And I put all the evidence together, but actually in 800 words, I really called out two big industries, both the food industry and pharma, with the overprescription of statins and the fact that low carbs, the evidence at that stage suggested low carb was a very effective intervention for reversing metabolic syndrome, which is, the biggest cluster of risk factors for heart attacks. So that's really where it I suppose got me a lot more. I managed to get that into the mainstream media. I mean, that was a BMJ's choice. They press released it, and something that was world news. And I think the fact that a cardiologist was saying that you can eat butter and it's not something to worry about, obviously at that stage was considered very controversial, but something that they felt needed an airing or a discussion. But in terms of what we do, I think there's a number of things that we need to do. I think certainly we haven't in the UK, and I suspect in many parts of the world, still got the nutrition education sorted in medical schools, both undergraduate and postgraduate training, specifically in relation to the impact of diet on chronic disease. Because our big, the big issue, the major issue around the world now is the fact that non-communicable diseases is causing the biggest strain on healthcare systems. And diet within that within the lifestyle hierarchy probably is the most important. Certainly one analysis in the Lancet Global Burden of Disease report suggests poor diets is responsible for more disease and death than physical inactivity, smoking and alcohol combined now. So I think that has to be a big focus. And then I think what we need to be doing as scientists, as clinicians, and of course science evolves and no study is perfect. Every study has elements of uncertainty to it. That's the beauty of medical science, is appreciating their uncertainty so we can keep evolving and developing more research to be more precise in our understanding of what works and what doesn't, is dissociation from commercial interests, because it hasn't worked. It's had a really detrimental effect. I mean, if you look, for example, at the pharmaceutical industry, certainly the last 2 decades in general, without naming any companies, I've spoken about this at lectures, and we've got data from all around the world. If you look at most of the drugs that have been approved, at least half to 75% of them, depending on which countries you're looking at, the drugs that have been approved by regulators have been shown to be just essentially copies of old ones. Yeah. So there's huge waste because they patent these drugs. The taxpayer often then pays for it. Governments pay for it, right? So there's a huge waste there. And of course, that in a healthcare system with finite resources, one doctor's waste is another patient's delay. So that's a big problem. And then you look at the innovations, they're very, very small in percentage terms of all the new drugs, certainly over a 10-year period and different analyses. Maybe 10 or 11% of those new drugs are thought to have an extra therapeutic clinical benefit over previous drugs. So there's a lot of waste there. And therefore, if you look at the whole picture of it, Anthony, one could very easily argue that the net effect of the drug industry in the last 2 decades on population, on society, has been a negative one. That's also understanding as well, busting some myths amongst even doctors and patients. Modern medicine has only had a marginal role to play in increasing our life expectancy. And that most of that role has been through acute care. So whether it's aspirin for treating heart attacks, coronary care units being developed, insulin for type 1 diabetes. You're going to die if you don't get insulin if you're a type 1 diabetic having ketoacidosis. Hemodialysis for kidney failure. These are sort of the big hitters that have added about 3.5 to 5 years to our increase in life expectancy of about 40 years since 1850. With most of those increases in life expectancy coming because of public health interventions, safe drinking water, seatbelts in cars, smoke-free buildings, safer working environments. So there's a few myths that need to be busted there as well. So I think that's what really needs to be done. But ultimately, the reason why people have a lot of these false perceptions, which drive behavior and even policies, Anthony, is because of commercial interests. Because you have these big corporations with a lot of unchecked power. They can determine the narrative. They control the knowledge environment now. Most studies now, drug industry, most drug studies are sponsored by industry, who then hold on to the data, and then it's not made publicly available, and independent analysis isn't done. So what does that mean? Well, in essence, the benefits of drugs are grossly exaggerated and the harms are underplayed, which interferes with clinical decision making, and then ultimately the patient suffers. And we can see all of that going on in society right now. So, one of the best ways for people to kind of understand that in a very clear and concrete way is a quote that came from the former editor of the New England Journal of Medicine, Marcia Angel, when I interviewed her for a Guardian article. And she said, the real battle in healthcare that we have is one of truth versus money.
Yeah. That's and I was going to say too, there was a recent article account. I really wish I remember what it was, but anyway, they were talking about the conflicts of interest of the Harvard professors at Harvard Medical School, and how they were all tied up with big pharma. They had a number of sponsors, and they had sort of like an F grade on their being tied up and not disclosing a lot of their ties to big pharma. And of course, they're pitching out to all the new medical students, hey, these are the drugs you got to do. There's nothing wrong with them. They're really, really good. One medical student, she was a first year there, just asking, okay, what are the side effects of some of these statins? What do those do? And the professor actually ridiculed her in class and actually made mocking remarks about her for daring to question the efficacy and safety of these statins. And it turns out that this guy was on the board for some of these places. And so there's a lot of I don't know, it's muddy water anyway, in the medical community and even in medical education, unfortunately. And you were saying, with treating metabolic disease with a keto diet, that's something you look back in the literature has been used since the late 1800s to treat diabetics, type 1 and type 2, to help really stabilize their blood sugar. And that's something that was so well established. for so long. And then, in 1977, when the USDA, decreed on high that cholesterol causes heart disease, it just everything just shut down, and we just forgot, an entire body of medical literature and knowledge. I go back to, JAMA and different publications, back in the 50s and 60s. There's just a heated debate about cholesterol, and people were just like, this is garbage. These are based on really bad studies, really bad science. We should not be listening to this. And it was very interesting to look back and actually see what the discourse was like back then, and then understand just how much of an impact that had, that we've just completely ignored everything that happened before the 1980s to do with our medical literature. It's very surprising to me when I started going down this rabbit hole, several years ago. I was very, very surprised and interested in that fact. It was a different world pre-1980. And now it's very different. And a lot of people say, well, we were probably still having all of those problems. We just, didn't notice it, because, anyone born before 1986 is just an idiot and just can't see what's in front of them. These are devastating diseases, and they destroy lives and take them very early. So, anyone to assume that these just wouldn't be noticed is a bit foolish. I don't think they're really thinking that far ahead.
Yeah, no, you're right. I think, it needs people to be critical thinkers, but it also needs people to be courageous. One of the things I talk about in my recent lectures is to lead the good and happy life, you also need to act virtuously. And if you have knowledge and you don't act on it, then it's vanity. Action without knowledge is insanity, but wisdom without having courage to speak up for your convictions is fruitless. Yeah. And actually what we need is more people just to think going back to basics about what does it mean to lead a good life. And actually, if more people were acting in a virtuous way with courage, then I think we would, a lot of society's problems would be resolved very quickly. Yeah. But people are being misled, and there's just too much power of these big corporations who are literally just profit-making machines. And in their pursuit of profit, acts in anti-human ways. The forensic psychologist that originally came up with or was certainly part of the original definition of psychopath, his name was Dr. Robert Hare. In the documentary film and in the book, The Corporation, he actually says that big corporations as entities, not the people within them, because they're doing what they're supposed to do, what they're legally obliged to do, but the entity that is the corporation actually behaves in a psychopathic manner. So if you think about this, Anthony, the way I've been thinking about this deeply is if you've got a culture and a power, if you've got, say, let's just say the psychopathic entity has increasing power that also influences culture, that which is anti-human, it's going to have a negative effect on us mentally and physically. So I think we need to think about that and changing the narrative, that actually the roots of a lot of these problems is what is the end result of a psychopathic entity that has a lot of power over institutions, universities. Most of the funding, for example, comes from drug industry research, comes from drug companies, now from prestigious institutions. And then it creates a culture that feeds the psychopath.
Yeah.
So what's going to happen?
Yeah, no, and that was something that reminds me of what like Jordan Peterson would say. Said if you want to change the world, like clean your room. And it sounds trite, but it's just like, no, you need to be able to take care of your own life. You need to be able to clean things up around you and get your own life in order. And you getting your own life in order will make the world a better place. And how are you going to fix the world if you can't even fix your own life? And some people, I think, because their lives are in disorder and disarray, and they say like, well, can't deal with this, so I'm gonna go order this around. That makes them feel a bit more in control when they're trying to do some sort of big grand project, and helps them ignore the problems that are in their life.
Yeah, and I think in relation to Jordan Peterson, I think I admire a lot of his work. I've listened to him a lot. I've read his books, and one of the things that really caught my attention, which made a lot of sense, is that he said it's not safe to speak the truth, but it's even less safe to not speak the truth, because even if you're preventing some potential short-term risk, you're actually pushing it down the line, and it will in fact become potentially greater. And if it doesn't affect you, then it's going to affect your kids. And a society that moves away from the truth, or increasingly is moving away from the truth, combined with our capacity for being empathetic, is going to have a very detrimental impact on the human condition, on human beings, on society. So, I think in broad terms, what we need to do is to start moving more towards creating the conditions where everybody certainly has better access to information and the truth, but simultaneously realizing that we don't live in cocoons, we are dependent on each other, and therefore our collective survival, or something that works well for society in its totality, is going to benefit us individually. And anything that has a negative impact on society is going to have a negative impact on us individually. And I think the COVID pandemic, in a way, has drawn that out a little bit more, that people have appreciated more and more that we're all dependent on each other.
Yeah.
And even if you are very wealthy, you've got access to all the information you want, and you are able to follow the healthiest diet you can, and you're going to be able to meditate and exercise, if the world around you is burning, you're not going to be happy. Unless of course you're a psychopath.
Yeah, I was going to say.
Or a sociopath, which most of us are not, thankfully.
Yeah.
So that's just my way of sort of, provoking people's thoughts a little bit more on this.
Yeah. Yeah. Yeah, definitely. I was going to say too, so being a cardiologist, obviously, heart disease is your bread and butter. We had I thought we had a great debate with the Australian College of Nutritional and Environmental Medicine. I don't think that the other team really appreciated us. I know they got really pissed at me when I just basically argued that, like, this isn't even a story. Like, look, this was all based on fraud. This should never have been a thing in the first place. They got really pissed at me, but which I think that's a good sign. If you are upsetting them, but people should watch that anyway, and they can get your sort of views on that. But it was a very quick sort of debate. It was only 7 minutes each person. Can you tell us your views on cholesterol and statins as well? You've written a whole book called Statin-Free Life. So obviously you have a different take than the mainstream, and obviously I would like to hear what your thoughts are on that.
Yeah, so I spent quite a lot of time. I've probably studied cholesterol and statins more than anything else I've studied, actually, certainly in the last decade, in a lot of depth, looking at research and trying to understand it better and unpick all the data. And really, to summarize the issue, certainly, the Framingham study that started in 1948, which was there to try and determine various risk factors for heart disease, which followed up about 5,000 people in the town of Framingham, Massachusetts, from the late 40s, for several decades. It's still an ongoing study, as far as I'm aware. And from that, various risk factors for heart disease emerged, smoking, lack of exercise to some degree, diabetes, hypertension, and of course, high cholesterol. But when you look back at that Framingham study, what they found was that the prediction of heart disease, a significant association of heart disease with cholesterol, was actually when it was extremely high. So in Australia, you use millimoles, do you, in terms of with people's cholesterol? Yeah. So I think over 300 milligrams per deciliter at least, and over 10 millimoles per liter was where you'd see the big association with heart disease from Framingham, which we now know, which we'll talk about in a minute, is essentially mainly people with familial hyperlipidemia, which is a genetic condition which gives people very, very high cholesterol and affects about 1 in 200 people. And at the other extreme, people with genetically very low cholesterol, less than 5% of the population, didn't seem to develop heart disease, although their lifespan wasn't changed from anybody else. So the thinking at that time was at the extreme ends, but most people in the middle, your total cholesterol specifically, and even LDL, didn't predict whether or not you're going to get heart disease or not. So the thinking was it was linear, and therefore we should, if we push people's cholesterol to be as low as possible, we are going to prevent heart disease. And in fact, Nobel Prize winners who are involved in understanding the role of cholesterol in heart disease, Brown and Goldstein in the late 90s even predicted that we may see the end of heart disease now because of statin drugs and cholesterol-lowering drugs that had come on the market and had shown from some randomized control trials that there was a benefit, even though lots of other drugs that lowered cholesterol before statins, even significantly, didn't show any benefit. And we know that dietary stuff lowering cholesterol doesn't. So I had to unpick all of that and put it all together. And the upshot is this, that first of all, unless your cholesterol is very, very high, an LDL of at least 4.9, which is usually the cutoff for familial hyperlipidemia, it's not very helpful at all in predicting whether you're going to get heart disease or not. But what is more predictive is your triglyceride to HDL ratio, which comes into this metabolic syndrome or metabolic health situation. That's just part of the story. So the upshot on the cholesterol hypothesis, Anthony, is that certainly lowering cholesterol in populations through diet or drugs, and we published a systematic review. I co-authored it with 2 cardiologists in BMJ and Space Medicine a couple of years ago. People can look it up. It's called Hit or Miss on the new cholesterol targets. Are they based on evidence? And what we found was just looking at drug treatment, not dietary treatment, because drug treatment has a big effect on lowering LDL and total cholesterol. There was no correlation, clear correlation with lowering LDL and preventing heart attacks. So that's very interesting. So the question then is, well, okay, do statins have any effect? Well, they do. The overall literature does show an effect in preventing heart attacks, stroke, and death, but then it has to be individualized and it has to be broken down in a way that's understandable for patients. So if you take people at low risk of heart disease, let's say that people who have a less than 20% risk of having a heart attack or stroke in the next 10 years, the statin data doesn't show any mortality benefits, so they're not going to live any longer, but there is around about a 1% reduction in heart attacks or strokes over a 5-year period. And then if you take people at high risk, essentially people who've had a heart attack already or have severe coronary artery disease, the benefits are probably 1 in 39 in preventing a non-fatal heart attack over a 5-year period, and 1 in 83 in saving one's life or preventing death. Now, why that information is important is that we should be having conversations with patients around this for informed decision-making, and that's something the WHO put out in a news bulletin in 2009, something that the medical oncologists in this country said 2015 in a paper I co-authored in the BMJ. So that's something that's been established, but again, it hasn't infiltrated into clinical practice. But just to answer the question that many people may be asking, so hold on, if lowering cholesterol is not a big issue, how do statins have the effect? Well, there is good evidence to show that statins have an independent effect of lowering cholesterol, which is anti-inflammatory and anti-thrombotic. And my view, and I've written about this in the book, I think that's probably the most likely mechanism of that small benefit of statins. Mm-hmm. But then if we're just focusing on lowering cholesterol and people then think they can eat what they like and they're having a high starch, high carbohydrate diet and they're increasing the risk of metabolic syndrome, that's really ultimately that scenario, Anthony, in my view, is actually having a negative impact on the patient. And one of the problems is there have been cardiologists, eminent cardiologists who've written, in fact, one wrote, and I talk about this in my paper and try and go through the points that this cardiologist made. I think his name was William Roberts, and he wrote in the American Journal of Cardiology in 2011. And it was entitled, It's the Cholesterol Stupid. And he makes lots of claims in this paper, which I try and counter in my book. But one of the most interesting claims is this. He says, you can be an obese, diabetic, smoking, sedentary individual, but as long as your cholesterol is low enough, you won't develop heart disease. So I had to take issue with that because we know even from clinical practice that's completely false and data that's there. But if you imagine an influential person like that and the impact he would have on other cardiologists, and they then have that as a mantra and it is indoctrinated, and I can tell you that it has been indoctrinated because I've worked in cardiology and been to conferences and spoken to many cardiologists and colleagues over the years, and it's false, then we've got a problem. Because if people, are prescribed, cardiologists are behaving or acting in a way based upon that, also without understanding the absolute benefits of statins, and certainly not having conversations with the patients around it, and then simultaneously not having the knowledge around the lifestyle interventions, it's not a good situation for us to be in, is it? In terms of medical management of heart disease.
Yeah. And so in your view, is there a time when people would benefit from statins? And you're saying that there's like an anti-inflammatory, anti-thrombotic effect. I mean, is this anything more than we're getting from aspirin, really?
Well, I think with all of these things, Anthony, we have to think that, just because something has a plausible biological mechanism, that isn't enough. So in medicine, today's truth maybe tomorrow will be often tomorrow's folly. And, just to give people an idea and a better understanding of that, medicine itself is not even an exact science like chemistry or physics.
Yeah,
it's
absolutely.
an applied science where we use the patient and the individual patient, but also look at it's an art in many ways, using probabilities from studies that evolve and change over time. And one of the quotes that I always start with in my medical lectures, and even teach my medical students this, is that half of what you learn in medical school will turn out to be either outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which halves you have to learn on your own. And because of the system, this isn't pointing fingers at doctors. I mean, doctors work very, very hard, you know that. But many of us, for unintentional reasons, may be climbing up the wrong wall in terms of our management of conditions based upon outdated evidence, and then don't have the time to update ourselves with the evidence, or even the critical skills to be able to understand the reliability of medical evidence, because we're not taught that in medical school. So all of these things contribute to this medical misinformation mess, and population health deteriorates because of it. So, and to answer your question, beyond biological mechanism, the best instrument we have to use to understand the benefits of intervention is the randomized controlled trial, and that, in terms of the hierarchy of evidence, is the best data we have. But even the randomized controlled trial can be rigged and manipulated by industry through the design and the interpretation of the results and holding on to data and all that kind of stuff. So that there are ways, and this is a longer discussion for another time, of how we can improve that. But one of the things certainly is we have to at least start by dissociating. One of the things I would say is, and I'm actually just quoting Cochrane researchers who said that after they reanalyzed data from a drug called Tamiflu, an antiviral that was supposed to be used for flu management, and we found ultimately, when the data was released independently, when it was originally marketed and we thought, and it was approved as being safe and effective, actually it wasn't very effective and had some significant harms. The conclusions of these Cochrane researchers that reanalyzed the data on Tamiflu when the raw data was released is that all industry-sponsored studies should be seen as marketing until proven otherwise. So what I would say is, moving forward, what do we need to do? Well, if we want to be good scientists, the ideal scenario, what we should all be striving for, is one, never rely on a single study to be approved unless it's a very huge effect size. And even then it should be the discussion with the patient saying, listen, this is an industry-sponsored study, which is what I say to my patients. So there's uncertainty about whether it's absolutely true or not, and it hasn't been replicated independently. So moving forward, the ideal scenario is we get, industry-produced products. We need them to produce drugs or whatever. They should be tested independently, and then we can be more confident in the reliability of the results. But even then, you want replication of those results as well. So I would say at least 2 studies independent of industry, randomized controlled trials, and then what do those results indicate in terms of absolute benefit? Then use that information. Now, some people might think this is pie in the sky and is impossible, but no, I think the situation has become so dire in terms of the net effect of drugs on society. One of the other figures, the third most common cause of death after heart disease and cancer, according to Peter Gosha, co-founder of the Cochrane Corporation, is prescribed medications, what your doctor prescribes for you. And he says that most of these side effects, these deaths, are preventable with better information. So if you think about that to start with, you realize this is a major, major public health problem. Mm. And therefore, we need to actually implement something, a different model in the system to improve that clinical decision-making. So sorry, to come back and answer your question, even if you've got a plausible biological mechanism, which is great, and we want that, we have to be able to match that with the trial data that gives you an absolute benefit on what a drug is doing. Because even if it has some anti-inflammatory and anti-thrombotic benefits, what else is it doing? Is it having a negative impact on mitochondria, for example? We know that statins have an effect on certainly reducing exercise tolerance in people who are doing moderate to vigorous physical activity. So what's the downside? So all of these things need to be taken into consideration. But the randomized controlled trial that's designed well is the best way, or the best tool that we have to determine the actual benefits and harms of any intervention we do, any drug. So, I'm paraphrasing the director of the Centre of Evidence-Based Medicine in Oxford, Carl Hennigan, who's brilliant. He's a practicing GP, a very smart guy, very high scientific integrity. And he says this, and I think this is a great line. He says, for every intervention you do as a doctor, you've got to ask yourself 2 questions. How much difference does it make? And how do I know this?
Yeah, that's a good question to ask. Yeah, I was going to say too, I mean, thinking it's like, well, you need, at least 2 studies, and that might be, high hopes, but, a study's only as good as its reproducibility. You do something, you make a statement, and you make a theory, and then you try to, show that. And it's like, okay, you do that. Okay, now do it again. Like, that's the entire point. I mean, that's the entire scientific method is the reproduction
Absolutely.
of that. Yeah. So I agree. Like
And that's not been happening, you see, Anthony,
yeah,
for so long. It doesn't happen as well as it should do.
yeah.
And that's because of that, really, there's too much power, unregulated activity of industry. And therefore, it's interesting. I said earlier that most of what's increased our life expectancy has been public health interventions, which really have been changes, regulations and law changes.
Mm-hmm.
And nothing has changed now. If you look back at the root cause of these problems that are affecting society in a negative way, it's unjust, unethical, and undemocratic laws that are perpetuating this problem. And therefore, we need to get to the root and change the laws for the problem to resolve itself.
Yeah. Sort of to that note, I know you've done a lot of work with Dr. Robert Lustig out of UCSF, and I know you just spoke in my hometown of Santa Barbara at the Metabolic Convention there, or what was that?
Yeah, Metabolic Health Summit. Yeah,
Metabolic Health Summit.
Yeah, in Santa Barbara, which I love, by the way, it's a great place,
Gorgeous.
Beautiful place.
Yeah, absolutely love. Yeah, that's where I grew up. My family saw there. My grandmother was in Montecito, which is a little area there. And my aunts, I have a few aunts and uncles and cousins there still, and I always love going back. It's such a gorgeous place. I've followed Dr. Lustig's work since he first started publishing his work on fructose in 2009. I was a first-year medical student and just happened to come across it. Actually, my dad came across it, and he just said, "Hey, you might be interested in this," and I was very interested in it, and I've sort of followed it since then. You've done some work with him as well. Obviously, you're you're very much aware of the fact that sugar is just toxic in my view. Can you tell me some of your work with sugar and with Lustig, and what sort of, I think you co-authored a paper as well together?
Yes, yeah, I've done a lot of work with Rob. In fact, we've co-authored, as far as I remember, at least 2 papers together. Mm-hmm. And Rob, I'll be honest with you, Rob has been my kind of guru on sugar. I mean, he really got me looking at sugar in detail. And you talk about replication, certainly the stuff he was writing, and one of his seminal papers was in Nature, on sugar. And I think it was 2012, if I'm not wrong. And he'd come out saying sugar is a major issue. Mm. And then I started doing my own research into it. But then I connected with Rob as well, because I wanted to ask him a lot more questions, understand where the uncertainties were, have a more definitive understanding of the science of sugar and fructose. So, pretty much everything I learned about sugar primarily came from Rob, and he deserves full credit for that, because I think he's an amazing scientist and an advocate. And again, he's not afraid to speak truth to power, and when with people I interact with as well, Anthony, I'm sure we all do this, I often start with, and this maybe is a human trait of ours, or a characteristic of us in terms of the way we connect with people. But for me, I also try and understand the human. Is this person someone with integrity? Because I think that does make a difference in terms of the stuff they're doing. It doesn't mean we don't get things wrong, but we need to start from a position of understanding the character, what really motivates them, and are they somebody that's acting with scientific integrity? And Rob is definitely ticks all those boxes. And then for me, I think the first publication I wrote about sugar, I'm glad you've asked me this question, it's quite interesting, because it was my own investigation. In fact, it was my first publication at the BMJ, May 2013. And it was called "The Dietary Advice on Sugar is in Need of Emergency Surgery." And what I discovered, first of all, is once I was aware of the science of sugar being harmful, and from a cardiovascular disease perspective, Rob co-authored a paper which was published by the American Heart Association in 2009. And what I found really interesting is in that paper, according to the up-to-date evidence at that point, and the people who were co-authors had no links to industry, so it was as independent as you can get. It was in those guidance in the American Heart Association paper, 2009, it said that for the average American citizen, they shouldn't be consuming more than 9 teaspoons of sugar a day if they're a male, 6 teaspoons if they're a female. And if you are a child aged between 4 and 8, the American Department of Agriculture has said no more than 3 teaspoons. Now, what's really interesting is at that point, when I looked at that and I thought, hold on a minute, what are people consuming? And I figured out in Europe, and figures were not dissimilar in the US, probably a bit worse in the US, that we were being told in the European Union through labeling on products in the supermarket that we should be consuming as part of our guideline daily amount, 22.5 teaspoons of sugar a day, Anthony.
Should be.
And I thought, hold on a minute, how there's a disconnect here between what's being published and and then I went in my own investigation trying to figure out, well, why is this science not matching the policy? And I basically didn't take long for me to figure out that companies such as Coca-Cola and the sugar industry were controlling a lot of that information through funding scientists and institutions. And therefore I exposed this in this paper and said, and called on the Scientific Advisory Committee on Nutrition in the UK, but subsequently the World Health Organization as well, and call them out and saying, hold on a minute, this is a big problem with sugar. And then the BMJ press released that paper and it became BBC News. I was on BBC Breakfast. It was picked up in a few newspapers. And then I'd already started writing a few articles about sugar anyway in newspapers like The Observer, which is very high impact in this country. So the awareness was increasing. And then we took it further. And after I wrote that paper, I was contacted by a number of scientists in cardiovascular disease research and, quite well-known, eminent, powerful people. And they read my article and said, listen, this is really good. Can you come and educate us on sugar? So I remember going, I was specialist registrar in cardiology at the time. I wasn't even a consultant. I remember going and I was a little bit like overwhelmed thinking, wow. So we sat around a table and I already learned everything I need to know about sugar and fructose by that time by Robert Lustig. And I told them, this is what's the issue. And it didn't take me long to say, listen, we need to form an organization called Action on Sugar. I was made their science director. And then I wrote another piece in the BMJ, Saturated Fat is Not the Major Issue, in 2013 October, which is all about saturated fat, but also said we should focus on sugar. That became a big news story. So I think that was gaining momentum and getting this information into the mainstream. And then we launched Action on Sugar. That became massive. It's front page of the Daily Mail, sugar is a new tobacco. I was involved in coordinating all of that, and it became a world news story by that stage. So that's really the how it all started for me with sugar. And then, there's lots of stories, but ultimately it involved me as science director of Action Sugar with Action Sugar, going and meeting the Secretary for Health, Jeremy Hunt, in 2014, and basically we gave him a child obesity plan, and one of those recommendations, which interestingly was a repeat of a recommendation I was involved with the medical colleges that represent every doctor in the UK on their obesity strategy plan in 2000 at the beginning of 2013, which was a plan to tackle obesity. We call for a sugary drinks tax. So we pushed Jeremy Hunt, and then I was pleasantly surprised not long after that, within a year or so, a couple of years, the Chancellor of the Exchequer, George Osborne at that time, came out. And in between, I was invited to 10 Downing Street to meet the Prime Minister, in events that were, I was being recognized for my role as an obesity campaigner. They came out and said, we're going to introduce a sugary drinks tax. And this was from what we call a conservative, or what can be considered a relatively right-wing government, which was amazing because, part of that ideology on the right has traditionally been, this is all about personal responsibility. This has nothing to do with industry. Industry are great. We create jobs, blah, blah, blah. So it was interesting to see that so that really was a measure of the impact we'd had as Action on Sugar. And of course, then I was probably, I've considered one of the lead, if not the lead campaigner that made that happen. So it was quite satisfying. Obviously, a lot more work to do. And for me, things have evolved from sugar, which is still a major issue, to linked to sugar is ultra-processed food. And I think the policy focus now should be on ultra-processed food and to some degree an education campaign on low-quality carbohydrates.
Yeah.
I hope that's answered your question.
Yeah, no, yeah. And I was going to say,
and Rob was part of Action on Sugar. Rob was one of the international advisors. So we got international people involved.
Oh, good.
And obviously Rob was, in my view, the sort of the scientist with the greatest amount of research and understanding of sugar and its effects. And of course, it was imperative to have him involved in that organization.
Yeah, no, he really broke the case open on fructose and just so very conclusively, but with hard biochemistry, like you said, like medicine is more art than science, certainly, or a soft science. There's a lot of junk science as well in the publications that we put out there, unfortunately. And but this is as hard science as it gets. This is actual pure biochemistry. It's like this molecule does this in your body. That's it, And so, I think it's one of the best pieces of nutritional science that we have are his work on fructose, because it's biochemistry now. It's just like actually pure biochemistry, which is awesome. I'm very much in the camp of, let people, sort of live their own life and make their own decisions. But at the same time, I think that things like sugar, honestly, should be at least age restricted. I think that Lustig showed very clearly that fructose is a drug. It's addictive in the same way as cocaine, heroin, and meth. Kills the same areas of your brain as meth, to the same extent as meth. You can see this on MRI studies that he's spoken about in a number of his talks. And we restrict other things that are addictive and damaging of this nature, especially for your development as a child. I mean, this is a major issue, and you're addicting children. I mean, the sugar's just in everything, and they promote it like, oh, look how great this is. And just walking around the hospital here, I'm sure you can feel my pain here. It was just every patient is served just the sugary, carb filled garbage. And I look at that, I'm like, the reason you're here is because you eat that. It's like we're feeding people the thing that's perpetuating their illness in the first place. Especially like cancer patients and heart disease patients, they're feeding them sugar and carbs. I literally just did a consult for a cardiology patient who had a STEMI a few days ago. And they were worried about his legs, thought he might have like, a spinal cord impingement. And so I went to go see him, and on his table was bread with jam and juice. What are you doing? You're giving someone who's just had a heart attack the fuel for another heart attack. And so I think that sugar, sugar tax.
We need to start in our own backyard, Anthony, as well. That's one of the things. When I first started campaigning, one of the major issues I took on board was, we should ban the sale of junk food in hospitals, and we need to set an example. And and that still hasn't happened really to any significant degree. We've got statements, we've got policy statements from various organizations in terms of the medical establishment, but the implementation hasn't happened yet. And until it happens, it needs to start there. If we can't win in hospitals, we can't win anywhere else, right? In improving the food environment. So.
Yeah. And, people, I think also just people just don't realize just how bad it is. I think it's just something nice and sweet. It's a treat. Oh, you're sick. Let's get you some chocolates, make you feel better. Not realizing that this is actually, a harmful substance. And
harmful independent of your weight, right? The evidence is there that independent of weight, it's harmful, negative impacts on your health.
Yeah, exactly. And you're giving it to kids and like, oh, well, the kids like it, they really enjoy it. And it's like, they'd enjoy cocaine too. Like you don't give it to them. There was a young child, I think he was in Indonesia. This kid was, he was an internet sensation because he smoked like 60 cigarettes a day, and he would do like tricks with them and like flip it around his fingers, and like blow smoke rings, and he's just this little chubby kid smoking cigarettes all day. And they did a news story on him that went viral, and they asked him, I was like, well, you sure you'd be letting him smoke? He's like, well, he gets really upset when we don't give him his cigarettes. He gets really, really angry, and he seems healthy and he's fine, so he's might as well just let him do that. I'm like, okay, for now he's fine for now. That's not going to last. Yeah. And of course he gets upset. It's a drug. He's missing his drug. And that's the same with sugar. Kids are freaking out, throwing tantrums. We've been using the vernacular for decades. It's a sugar high. Yeah, well, that's because it's a drug. It actually is. That was more accurate than people realize. But we recognize this intuitively, that this was a sugar high, that they're coming down off sugar, and they want their sugar fix. These things. I heard these phrases bandied around when I was a child. So these aren't new terms, and now with Lustig's work and your work is showing very conclusively that this stuff is an actual drug and actually should be at least age restricted, I would think. I don't know if you've in the same camp on that one.
No, 100%. It doesn't have any nutritional value, right? And there is emerging evidence certainly to suggest for many people it's addictive, and addiction is the opposite of free will. And in particular to protect kids, I think that you're right. That's where there needs to be bigger restriction. It doesn't mean, listen, we all like the occasional treat, but it's just infiltrated itself into people's meals in some way, shape, or form 3 times a day. as
Yeah.
opposed to, a couple of times a week or whatever. And that's the problem.
Yeah. Is there, just to sort of jump to a tangent, or basically to the left, and maybe we'll sort of wrap up after this. Is there, obviously we talk about fructose being a problem as well, but there's also, people talk around, like in the different, carnivore communities and keto communities, that, like, things like seed oils are very damaging and detrimental to our health, and particularly cardiovascular health. Do you have any insights about that sort of thing, using these vegetable oils and cooking oils as well?
Yeah, so I still think there's a bit of debate about the issues on seed oils, only in that, and I've written about this as well, the harmful effects seems to be most prominent when you cook in these oils, absolutely. So when you cook in these oils, and for common frying purposes, these seed oils, they produce these compounds called aldehydes, which are clearly have some link to cancer and heart disease. And therefore, I would avoid, and I advise my patients to avoid cooking in them. Whether they have that similar effect when they're used in a pure kind of form, in a cold pressed form, for example, I think it's difficult to know for sure. But what I would say is, actually, we've got better oils that we know are safe and probably healthy to cook in. I always go for good quality extra virgin olive oil, but of course you can also, coconut oil, even butter, lard, that kind of thing. But from a heart disease perspective, the only real data we have, which seems to show benefit from sort of oils, if you like, comes from extra virgin olive oil. And there are lots of properties of that, whether it improves HDL function, it's anti-inflammatory, observational data, some randomized control trials. So I think at the moment, I would say the default is, from a heart disease perspective, would be to go for good quality extra virgin olive oil, which is a fruit oil. But I do generally avoid. I certainly avoid it, and I think we need a bit more better data in terms of any kind of trial data on the seed oil stuff. But yeah, the direction of evidence suggests that it's probably harmful. Yeah, okay. Absolutely.
Yeah, and then just last question, promise. What are your views on diet now? They've seen like a low carb, high fat sort of diet. Obviously, I promote like a carnivore diet, and just argue that biologically that's where we came from, and that's our biologically appropriate diet. What is your thoughts on diet now? What sort of diet do you follow?
Really good question. So obviously the information's evolving and changing, and I think the most important thing, where hopefully everybody can get behind, certainly whether you're a carnivore or keto or real food, so both real food, but is minimizing the low quality carbs, if not eliminating them, and eliminating ultra processed food. So eating real food, I think, should be the main message, and then tailor it for the individual. Certainly, I know patients that have done really well on carnivore. They feel better physically. They have reversed their metabolic syndrome, for example. There is anecdotal data on autoimmune conditions. And I think this is fascinating, and it needs a lot more research through funding to look at the carnivore diet in detail. And I certainly haven't seen anything so far that suggests that it's particularly harmful if followed in the right way, because of course it's very nutritious. The question that we need to ask is, where there is some research, and of course every bit of research can be, there are uncertainties attached to it, is if you look from a heart disease perspective. I wrote a paper in 2017 in Sports Medicine to try and shift the paradigm in the understanding of heart disease, that it's a chronic inflammatory condition that is exacerbated or influenced by insulin resistance risk factors. Is there an anti-inflammatory component to food? And this does seem to be anti-inflammatory components to things like extra virgin olive oil, nuts and seeds, whole fruit and vegetables, for example, oily fish, omega-3. So I think we need a bit more definitive data on whether those types of foods are having an anti-inflammatory effect in relation to heart disease. But I also know there is certainly some anecdotal evidence that suggests that, plants and certain vegetables can be pro-inflammatory. Now, is this because of the way that they are produced in the modern day, as opposed to, what was being consumed 40 or 50 years ago? Or is there something else going on which is specific to certain individuals? And we don't know the answer to that. So there's a lot of uncertainties there. But I would say for patients, my default as a cardiologist is really to recommend a low carb Mediterranean style diet. And certainly for my patients, the metabolic syndrome, that seems to be the best approach for reversing the metabolic syndrome. And of course, I also look at inflammatory markers, high sensitivity CRP and that kind of stuff, and that gets better. But it may not be for everybody. And certainly with weight loss and people who really want to, who stall on their weight, then you've got other options. And I write about this in my book. I think mentioned carnivore, but even going higher on the protein. So Ted Naiman has done a lot of interesting advocacy on this. And I think a lot of the stuff he says makes sense. So for me personally, I'm still very much a Mediterranean style diet, low carb, not moderate low carb. It used to be moderate low carb. I'm lower than moderate low carb now. I tend to eat my carbohydrates, unprocessed carbohydrates, through, or whether it's even, some grains in the form of oats around my workout. But really, after lunchtime, I don't have anything starchy whatsoever. So it's pretty low carb. But because I work out and I lift weights, I tend to be quite high in the protein, and it's working quite well for me. Certainly all my metabolic risk factors are in the best place. I haven't quite got a six-pack yet. I'm working on that. And that's not for any health reasons, because, I think that people can get too obsessed about six packs and that kind of thing. But I'm just experimenting on myself a little bit, because my genetics and my family history, there's no one with a six pack in my entire extended family. Yeah. And that little bit of subcutaneous fat around the belly, I was like, okay, well, how far can I push this? Can I actually get rid of even that subcutaneous fat? Because my visceral fat index and everything is outstanding. Yeah. My metabolic health is perfect from those parameters. But I'm just pushing myself a little bit just to see whether I can, for myself, just how far can I take it? But it's not something I'd necessarily in any way recommend that people do. But, people are vain and people want to push themselves to the limit and all that kind of stuff. So I understand why people do it. So that's where I'm at the moment. So let's say work in progress. I'll keep you posted on that.
Nice. Well, go carnivore, you'll get a six-pack 2 months. I'll call it right now. All right. All right. Well,
maybe I'll try that next. Maybe I'll move on to carnivore next.
Yeah. Awesome.
I'll give that a go for sure at some point. Yeah, absolutely.
Yeah, you should. Well, great. Well, Aseem, thank you so much. I don't want to take all your time. I really appreciate you taking the time out to speak to me today. I think this is very beneficial. I've obviously talked about the cardiology issues and cholesterol, but I've literally quoted, your study. So it's really good to have everything coming from the horse's mouth. And I think everyone will really appreciate it. Where can we find you? How can people follow you and support your work?
Sure. Thanks, Anthony. So yeah, I do. I'm on social media. Most of my activities on Twitter as Aseem Malhotra, Facebook and Instagram as Lifestyle Medicine Doctor. That's where people can find and follow my work. I also have a Patreon because I'm, about 80% of my time I'm doing stuff that doesn't fund me in any way. Writing articles and doing media work doesn't give you, but I'm an activist. I get that. So any help people can give me through that is obviously very much appreciated. All of my, knowledge shouldn't be commodified. So I share all the information freely. People can get my books and read my articles.
Yeah.
Just by putting my name to Google and putting anything they want, sugar, cholesterol, statins, it's all there.
Lovely. All right. We'll put all those links up and get your websites and everything like that as well. And thank you very much. I really appreciate your time. I hope you.
My pleasure, Anthony. It's been great. Really enjoyed the conversation with you. Take care.
You too.